Good morning again, everyone. I'm Faye Jackson. I'm the General Manager of Inclusion at Flourish Australia currently, and I'm on the National Consumer Carer. What is it I'm on? The National Consumer Carer Register, and doing some consultative work with the National Commission and all sorts of things. So I've been around for a long time, obviously. So hopefully we get some more people coming in, but it's not about how many people are here, it's about who's ready to listen and who's ready to speak. We know our speakers are here and ready today. The subjects that they'll be speaking on, Chris Maylea is speaking first of all on what do we mean when we talk about physical health. Caroline White is talking on reviewing physical health guidelines through a mental health lens. Matthew isn't here today, but Victoria and Elise are, and Victoria Palmer is speaking about co-producing assertive cardiac care with and for people with lived experience of mental health issues. So we wish them all the very best, and I don't know about you, but it's been a bit, for me, this is my first foray out into public and out into conferences, and I'm a bit nervous about it. I hope that we sort of relax more over time, and I hope we don't get sick. So, I look like this. Ta-da! Okay. All right. So, Chris, you're up first. So, Chris's title is "What Do We Mean When We Talk About Physical Health? Preliminary Findings from an Equally Well Health Talk Collaborative Project." Chris Maylea is a social worker, lawyer, an associate professor of law at La Trobe University and a member of the Equally Well implementation team. Chris has done amazing things over a long time, and it's been a great privilege of mine to know Chris over different projects and ventures, but always heading in the right direction, and so I feel really honoured to be hearing Chris speaking today. So thanks, Chris.
Thanks, Faye. That's a lovely introduction. Hi, everyone. My name's Chris Maylea. Lovely to be here. I think the last conference that I went to was the Equally Well conference in 2019 that got... then we had to postpone it 3 times, and now here we are. So lovely to see you all. I'm talking today about a Health Talk Equally Well partnership project that we first pitched in, I think, 2017, and got off the ground in 2018, and got off the ground in 2019, and is still going now. We will have a launch, and the final resource will be available later on this year, and so I'm going to tell you where we're up to with that, how we got where we are, and what we found out. It's a partnership between Equally Well and Health Talk Australia. The universities running the project are La Trobe University's now lead, RMIT was lead, and RMIT is now a secondary partner, as is Charles Sturt University. So it's a really good example of this constellation model that you would have heard about in the first session. Different organisations, different key stakeholders doing different things to progress the main goal. And so Health Talk has this, you've heard a lot about Equally Well already this morning, so I won't go into that again, but Health Talk has this long background in creating online resources for different groups of people, talking about their experience of using health services or of having health conditions or whatever. And then the idea is that people can kind of get it's like a virtual peer or something. If you can't find someone to talk to that has had your same experience and can share their experience with you face to face, that's always best, right? In terms of genuine peer work, and we're not saying this is going to replace it or anything like that, but it's a resource for people to use to get that same energy. Oh, look, here's someone that's had that. So, for example, another Health Talk project is on there's an infertility one, so women that experience infertility at different stages of their life sharing those experiences. And you can see how powerful that would be if you don't have anyone around you who's ever had that experience to hear the experience of other people in that way. Anyway, so that's what Health Talk does, and then partnering with Equally Well on this project. So we're going to create an online resource as just described. I don't actually know exactly what it's going to look like yet. The Health Talk model has a kind of way of doing videos, but in the last few years we just did a Health Talk project on people's experience of going to the emergency department for in a mental health crisis, and we did a range of different things, podcasts and little animations that are cool on social media, as well as longer format kind of here is my story start to finish videos. So I don't know, we are going to do some consultations, so it's not impossible that we will put something out in the Equally Well newsletter. If people are interested in giving us feedback and advice about what would be useful for them, then keep an eye on the Equally Well newsletter, because that's where we'll yell at if we get that far along. Now we want co-design. This project, within the loose grouping of like what is co-design, like maybe we scrape in. It's really hard actually. For me, I'm quite critical of a lot of projects that claim to be doing co-design and then are not. And we did try to do co-design on this, but I think at this point I would say it's short of the threshold. I think the reason I will say that is because the ultimate decision making is not sitting. It's shared, absolutely, with consumer researchers, but the nature of the health talk side of things is that here is a way we do things. We have a model, we have a process already, and that's a bit flexible, but if the co-design group says, no, we want to do this instead, it's no longer a health talk project. And so at that point it stops being co-design because we've got this quite stringent requirement on it. The other thing is, although we have improved this over the years, and again, as this was conceptualised maybe 2018, something like that, and I've learned a lot about co-design since then, the way in which we use people in different roles, and so having been, as I am, an academic with lived experience, doesn't make me a consumer researcher, and so on a genuinely co-designed research project, we all have to go through this really difficult process of working out what our roles are and whether, and for me, my mental health experience has severely impacted my physical health in different ways over the years. And so I feel like in some ways, yes, I get to be a consumer researcher on this project, and then I back away from it. I'm like, no, I can't, that's too many hats, right? Too many hats. And so all of that mess, I just want to lay that out there as a bring in the vultures to pick away at whether this project is co-designed or not. I know we're hearing about other co-design projects in this session, so I thought that was a useful thing just to be kind of like practice some radical honesty there. I honestly think you could have 10 different people say 10 different things about how well we've done in terms of co-designing and including and sharing decision making and all those sorts of things. So anyway, keep going. The participants are drawn, so the funders, actually I should have started with the funders. I know there's some funders who are at the conference today, so I'll acknowledge them. It's co-funded by the National Mental Health Commission, Victorian Department of Health, now Safer Care Victoria, and the New South Wales Mental Health Commission. So the participants are drawn from New South Wales and Victoria. We spoke to 33 people distributed in rural, regional and metropolitan areas. We spoke to more women than men, and that's pretty common in studies like this. We tried to address that a bit. We had a kind of Twitter, hey, who wants to come and talk to us? And we did it through social media. But we also worked with NEMI quite closely to access people who otherwise would, people without mobile phones, people whose support workers drive them to every single appointment and who otherwise don't leave the house. So, not a full range, but a maximum variation sample is the technical term for how we went about the who we wanted to speak to. But it's basically as many people, getting as much diversity in as we could. Here are the diagnoses that people came with. You can't really read them, but that's not really the point. I wasn't going to leave the slide long enough for you to read them all anyway, but it's just this incredible diversity from fertility to cardio to people talking about their experience of seeking trans affirmative healthcare. I don't know what probably half a dozen of these things even are. So, there's a real, when we're talking about physical health, there's I think a focus in general on cardio and heart disease, but actually the broad range of consumers that we spoke to Didn't talk about, I'm going to talk a bit about this in a bit, but didn't talk about smoking, didn't talk about cancer, didn't talk about the things that if you get 10 clinicians in a room talking about this, 9 out of the 10 of them, probably 10 out of the 10 of them are going to mention smoking and cancer at some stage. I'm not saying we shouldn't talk about smoking and cancer, but the clinical lens that is drawn on some of the data that we saw earlier on today doesn't coincide, doesn't concur with the consumer perspective. Surprise, surprise, who would have thought that? What does, no, this doesn't concur with what the clinicians think either, but what we did see, every single person said, I have been discriminated against. That was just a fundamentally overarching theme. Very commonly, so some examples of that, people would say, I won't go near the health service because I just know they won't take me seriously. They've just never taken me seriously, so I'm not going to go back there. I've got one GP that I like, but they've retired or something, you know. So people did describe really good, positive relationships with clinicians, but this isn't a quantitative study, so we can't say X number of people who experience compulsory treatment had this, you know, percentage of resistance to engaging with hospitals. But people who had, I'm going to say it anyway, people who had experienced compulsory treatment didn't trust the health service system. And so I don't know that I've ever heard a clinician kind of make that link in the way that I think we're seeing it come through in our study in the role of compulsory treatment and force and coercion and blame and stigma. You know, we hear about destigmatising, but that's kind of really real in this study here. So discrimination is a very, very significant overarching theme. Another overarching theme, this one won't surprise you, is medication. Of a range of different types. One of the big things we got was the prioritisation of the elimination of so-called mental illness symptoms, however people construed those. We didn't define those, we just let people talk however they wanted, which is my favourite way to do research. And they said consistently words to the effect of, it didn't matter if it was going to take 20 years off my life so long as it meant that they could be discharged, you know, from the hospital within a reasonable time. People didn't feel like the long-term impacts of psychotropic medication were being taken into account when prescribing in the mental health system. Surprise, surprise. But do you know what? There's not a lot of research that says that. And so we have to do this kind of really basic research to a large extent because it's important to do, and the solutions are found, I think, in these consumer perspectives. We, as part of this project, we did a lit review where we reviewed, we pulled in the first tranche. I don't know if those of you done lit reviews, you know, you start big and then kind of whittle away. The first search we did had about 6 million hits, and of those, I think we found about 140 studies that genuinely sought to find or to describe the consumer perspective. That's going to be published this year, hopefully. But there's lots of research. You saw this one that was put up on the slide today of the increasing amount of research in this area. It's not that if you had that line of the 20,000 papers that have been written on this topic in the last few years, a handful of them genuinely ask consumers what they think about this situation, and then when they do, almost all, not all, but almost all of those then mediate it through a clinician researcher's perspective and say, here's what the clinician said. Something that won't surprise a lot of you, I think. They asked a number of studies, not all of them, but a bunch of studies, asked clinicians and carers policy-related questions and then didn't ask the consumers those same policy-level related questions. So they asked consumers to help them identify what the problem is, but then the solution that's proposed is carer and clinician perspectives. And not that they should be excluded entirely, but we saw this pattern. Okay, not an overarching theme was cancer, and this is an interesting one because cancer is a major killer for people that use mental health services or that prescribe psychotropic medication, and so that's really interesting that it's missing. I think it's generally because of we don't know, but we're recruiting across the lifespan, and in general, and I know there's some survivors in this room, and so, you know, the very big generalisation, but in general, people do get cancer and die of cancer later on in their lifespan, and so we're just not picking them up in this research. So people probably aren't talking about cancer because of the people we're speaking to are not all in that space. But still interesting, people aren't being told your cancer risk is much higher as a result of the medications you're on. Because if they were being told that, then that would have come up in our study. So there's not an awareness of the side effects, the long-term debilitating side effects of these medications. Not an overarching theme, smoking. Only 2 people talked about smoking of the 33, and only 1 said, oh yeah, I'd like to quit. Although I haven't got the number in front of me, but a lot of them were smokers. So it just wasn't a priority. And there's 2 ways you can look at that. You can say, I mean, there's a million ways you can look at it, but I think 2 things that we're taking into account in our analysis. One is that if you go to the doctor and the doctor's trying to treat you for a diagnosis of schizophrenia, they don't prioritise saying, hey, would you like help quitting smoking, right? That's diagnostic overshadowing. But then there's another side of it that I think is coming through quite strongly in our data, which is smoking is the last thing that I have control of. You're not taking that away from me too. And so there's a couple of different dynamics there, and I think understanding consumer perspectives on smoking and relationships to smoking is an area that we really need to tackle more. We've got dozens, hundreds probably studies of smoking effectiveness programs evaluated in the inpatient setting, but actually understanding what's going on for people, that hasn't been done in a lot of detail. Not an overarching theme is exercise. It's just not a focus. People are talking about their own experience and the sense of being discriminated against. There's this real sense that actually we need to address those underlying issues, and then the other stuff will fold out. Right? The other stuff will get itself right when people feel valued and included members of society. That's certainly what our data is telling us. People did talk about the exercise that they did, but it just wasn't a big focus from that consumer perspective. Now, again, you can look at that in 2 ways. People aren't being supported to exercise, or because of the social isolation, because of the cost of gym memberships, because of the metabolic syndrome, the consequences of taking medication, people aren't able to exercise, right? And then the clinicians are like, oh, why are these people exercising? Let's get them in an exercise program. Well, hang on, you've missed the whole middle step there that's enabling and providing supports. My first slide that I did on systemic failures was like 4,000 words, so I tried to cut it down. But consistently, most of our data that we collected was about this failure of care coordination. So I actually had to run off. I was involved in writing the program, but I somehow managed to put myself in 2 different concurrent sessions. So I had to run off and talk about this other project we did an equally well evaluation about care coordination. And in that program, we found care coordination's great. It's really good at increasing access, but then the services aren't even there when people if you've got a nurse coordinating your care, unless they can magic up services out of nowhere, it's not much good. So that care coordination always needs to be done in terms of also increasing available and affordable services. This issue of dismissal, because just like a lifetime of being told you're making this up, or it doesn't matter, or it doesn't count. The number of people who we were told, you know, I went to 15 different doctors and all of them rejected me. Turns out I've got this rare blood disorder, or it turns out I've got this, or it turned out I've got this. This person wasn't in the study. As mentioned before, I'm a lawyer. I had a client who had used a pen to self-harm, and the tip of the pen broke off and stayed inside. And the prison, it was in a prison, and the prison said, "Oh no, it's fine. The pen can just stay in there. It's all healed up nicely now." And so, you know, these kinds of just repeated, how's he ever going to trust the prison health service ever again after that one experience? And so I think this is a real important lesson for clinicians is it doesn't matter how great you are, it doesn't matter what a fantastic clinician you are, if the 10 clinicians before you were all dismissive and terrible, or the system before you was dismissive and terrible, you have to accept that you are going to be viewed within that same light. And that's a really challenging thing, I think. I was a social worker, I'm a mental health social worker, and I think that was a big awakening for me when I realised that, particularly in regards to child protection, that I represented this whole state apparatus that people who have been battling their entire lives were saying exactly the same thing in mental health. A lack of trauma-informed care. Pretty much all of the women we spoke to raised a lack of trauma-informed care. And I think it's interesting, we're seeing in Victoria, we're seeing like trauma centres or trauma experts being inserted into the space, and yet like what we actually need is for just every single person, like the bus driver, you know, the like, oh my God, the security guards, like everybody to be operating from a trauma-informed perspective, because it only takes one person not to have that understanding in a service and you just completely wrecked. That whole service experience has not only been wrecked, it wrecks future service experiences for people for a long time. Women described having much less faith in the system. Men described being believed, having the information they needed, but having unhealthier lifestyles. So men had more control over their own health choices as a rule. Again, not a quantitative study, just an interesting thing that came out of our analysis. Surprise, surprise, this isn't something that I picked up when I was analysing the data, but it was something that other members of the team of diverse genders picked up. And so I think that's a really important thing for us to kind of take away, is that diversity, intersectionality, there's a range of things going on there, but the gender differential is a really big one. Future plans, we've got the risk research launch coming in 2022, so that will be the online digital resource. We will be coming to clinicians and consumers and carers and saying, hey, what do you think about this? How should we do this as we go forward? So we'll put a note in the Equally Well newsletter, and so if anyone's interested in being involved, that's good. We'll be writing up our findings, doing publications. The lit review, systemic lit review, should be coming out this year. And then I'm starting a new project which is kind of falls on the back of this one, which is an Equally Well consumer self-advocacy resource. So there'll be a kind of, I don't know, we're going to co-produce it, so who knows what it's going to look like. This time I promise it'll be real co-production. It's going to help you basically either paper-based or online or something, I don't know. You'll fill it out online and then go, all right, here's what I want to talk to, and tick this box, and good, and then you print out a thing and you take it to your doctor, and it'll be endorsed by the College of Psychiatry, College of GPs, and then so you can have a conversation informed by the best up-to-date kind of medical knowledge, so you can take in lay language, your side effects for the medication that you're on, and say, okay, help me understand what's happening here. This, like, empowering people. We shouldn't have a system in which we need to empower people to interact with their doctors, but that's what we have. So that's kind of coming on the back of this project. That's it from me, and I finished with 2 minutes to spare. Look at that, Faye. Aren't I well behaved? We do have a roving mic. I tell you what, if you want to yell out questions, I will just repeat them so people at home can hear them, if anybody's got any questions. Thank you.
I have a roaming bike. If anybody,
yeah, just while the mic's arriving, I will. You can go on Health Talk Australia and see all those projects I mentioned. I will tweet the report link as well today at some point. So for the I'm getting confused. That's the other project.
Thanks, Chris. Really interesting. I've got lots of questions, but the thing that we've been hearing lately as well is around the intersecting issues around legal rights.
Yeah.
And I just wondered if you had a comment on how we start to, design and develop tools that are starting to bring in these other elements. So I'm hoping your consumer resource that's forthcoming may be able to address some of that, because we're hearing a lot about that too. So
I wish, like, goodness, that'd be lovely. We're not gonna move the needle on people dying early in the mental health system until we fix the mental health system, and that requires removing coercion and providing people the opportunity to make choice. And so, of course, if you have a range of different conditions of whatever description, and you can say, right, I'm prepared to take 10 years off the end of my life in order to get, more quality of life now, and I can make that choice, but that's not a choice that's being offered to people in the mental health system. And so I think that's just the reality, is that what we're doing with these resources is really important. It's going to help a lot of people, but that kind of fundamental change, the intersection with legal rights, the realisation of the human right to health, requires fundamental systems change that we're not up to yet.
Is there time for one more very quick question? Yes. Come on, darling. Wait, darling.
Don't make Faye run. That's
No. I'll hold it.
Thank you. My name is Veronica, and I'm working for Care Coordination Service. So when you mention about care coordinator, I think one of the barrier is that some of the GP, they actually don't really know about social prescribing, and they are hesitate to involve with us. I'm just thinking, do we have any resources try to promote this knowledge to the GP, let them to understand more about the mental health, rather than just looking at their prescription to the clients every day?
Yeah,
Fantastic
look,
question.
equally well, he's doing work on that. It's a great question. So it's about social prescribing and general practice. The College of GPs is doing some work in collaboration with Equally Well on that. I think it's good, they should be doing more of that sort of stuff. But if we've got GPs doing that role, that suggests that we've got a pretty big gap somewhere else in the system. Like, GPs are really good at quite specific things. I don't think we should be asking them to be social workers as well. And I think a lot of that social prescribing stuff kind of pushes them in that direction. And most social workers aren't that great at being social workers. Like, let's not throw GPs under that bus as well. So, yeah, I think I'm a social worker. I might say that. I think in terms of the social prescribing stuff, I think we're heading in that direction. But what we're doing there is medicalising, basic access to society and basic human interactions. And we shouldn't even be professionalising that with social work intervention, let alone medicalising it with GP intervention. So as much as it fixes a problem immediately, and the data's quite good around it, again, it's that broader system change that it points us to needing. Yeah,
That's great.
I'm done.
Thank you, Chris.
Thank you so much.
So
You've been
please
great. Thank you so much.
Chris again. That'd be great if you can put there. Chris, I really value how you started off your speech too in a few ways. You talked about what true co-design is, and you put your hands up to this was intended to be but didn't reach the bar. And I love you for that. I love you for not pretending or not trying or not convincing yourself that this is true co-design when it actually hasn't been. It's collaboration and involvement, and
It's still good.
It's still good.
research,
That's right. But it's not co-design. Yeah. So I really value that. That's honest, and it's integrity. It's beautiful. And also, I really valued very much that you said that you were a researcher with lived experience, not a lived experience researcher. And I really value that you've recognised the difference between those two, and all of the advocates, lived experience advocates, really value when people recognise that, and because it's very important that the lived experience space doesn't become overshadowed or overcolonised by what the degrees or the not by you, by the degrees or the clinical outlook or whatever. So thank you so much for that beautiful